Good morning, good afternoon, everyone. Thank you for joining this webinar organized by SBRI in collaboration with the CDC and Together for Girls. My name is Constanza, and I'm glad to be moderating today's event. This Africa-focused webinar will provide an overview of the Violence Against Children and Youth Service, discuss how they can support global research on the intersection between violence against children and violence against women, and also explore how to use the VACs to translate data into action. So before moving to our speakers, I would like to share with you some housekeeping rules. So the webinar will last 90 minutes. The session will be recorded. All participants are mute, but you can ask your questions in the chat box. In the Q&A box, and present yourself and introduce yourself in the chat box. We have French and Spanish interpretations. You can find also in the interpretation box. And all webinar materials will be available at SBRI website and at Together for Girls website. Sorry about that. We will have French and Portuguese interpretations. I would like to give you an overview of the webinar today. We will have colleagues from the CDC giving an overview of the VACs, and then we will hear from early career researchers who actually use the VACs data in their researchers. So why don't we start? So first, we will hear from our colleagues from the CDC, Laura Chiang, Dr. Stephanie Miedema, and Francis Anor. They will, as I already said, they will provide an overview of the VACs and the indicators related to violence against children and how to access and use the VACs data. So Laura Chiang is an epidemiologist and serves as implementation team lead for the VACs. Dr. Stephanie Miedema is a health scientist who works on the implementation team, supporting the implementation of the VACs in different countries. And finally, Dr. Francis Anor is an epidemiologist and serves as a data team lead for the VACs. So Laura, the floor is yours.
Thank you so much. I'll just get the slides up. All right. Again, my name is Laura Chiang, and good morning, good afternoon to all of you joining. Thank you so much. We're really excited to talk to you about this survey that we think is such an important contribution in the field. And we hope that you all come away believing and feeling that, and access the data to do your own analyses and work. So next slide. I think as many people on this webinar are aware, an estimated 1 billion children experience violence annually, or about half of the world's children. And if this was an infectious disease, you can imagine there would be this massive galvanization around this. If the headline came out that 50% of children would be infected with malaria, but violence is understood more recently as a public health issue, and this survey and other data sources are really shining a light on the importance of this as a public health issue. Next slide. And I think this slide does a really good job of explaining why it's so important to understand violence against children in particular as a public health issue. In public health, we often talk about violence as a linchpin health issue because of its connection to so many other health and negative consequences, both in the short term and across the lifespan. So there's often injury associated with violence at the time that it happens, such as burns and head injuries. But there's also a host of other outcomes, such as mental health outcomes, maternal and child health issues. Violence experienced in childhood can really limit someone's life opportunities, such as education and employment. We also see that violence is associated with a host of risk behaviors such as smoking or unsafe sexual behaviors. And then finally, violence against children has very clearly been shown in the literature to be associated with most of the leading causes of mortality and morbidity and mortality, like chronic diseases such as heart disease and stroke. So it's really important to be studied and understood more and more. Next slide. We also know that violence against children and violence against women is linked. And this is for a number of reasons, but there's often shared risk factors. Often there are harmful social norms that exacerbate or allow the violence to continue. We find that violence co-occurs, often even within the same household by the same perpetrator as violence is happening. There's an intergenerational aspect to violence. So we know that people who experience violence in childhood are more likely to go on and experience it in young adulthood. In turn, we also know that people who experience violence in childhood are more likely to go on and perpetrate violence in adulthood. And then finally, adolescence is this period between childhood and adulthood that we know is so important. It's also often referred to as the forgotten demographic because it's not as well understood, and there's so much happening in this time period as someone moves from childhood into adulthood, and their brain is expanding, their experiences and their social networks are expanding, and they may be particularly vulnerable to violence. Next slide. So as many of you may be aware, the SVRI created, sorry, just one second. Apologies, my slide was really small. So SVRI has this research agenda, and a number of you perhaps were involved in providing input in the research agenda. But people provided a lot of input on what would be the priorities. And you can see that in particular, the VACS is a very useful tool for a number of these priorities, certainly under domain number 2, understanding the impacts of various forms of IPV on women and girls. And the VACS does, in fact, include data on emotional violence, as well as intimate partner violence. And then under domain 4, priority number 2, what methods can be used to measure the intersection and pathways between different forms of violence. And so as we've just discussed, the VACS provides an opportunity to understand the intersections between violence against children and violence against women. Next slide. So now I'm going to talk a little bit more specifically about the VACS. So the Violence Against Children survey is implemented under the partnership of Together for Girls, and you can see it's a public-private partnership, and the logos of many of our key partners listed there. The U.S. Centers for Disease Control, so the agency where I work, we serve as a core partner on one of the 3 pillars that Together for Girls is focused on, and that is the collection of data to really shine a light on violence against children and work to eliminate it in the world. And we've actually provided technical assistance for each of the VACs that have been implemented. Next slide. So the VACS is truly a comprehensive data source on violence against children, and it represents about 10% of the global children. And next slide, you'll see on this map where the VACS have been implemented. We have implemented VACS in Africa, Asia, the Caribbean, Eastern Europe, and South America. And we have plans to implement a pilot study in the United States. You can see in particular Southern and Eastern Africa is very well represented in VACs. We have just a massive amount of data from this part of the world. And we're really excited about the fact that VACs is now being repeated in countries so that we can understand how the prevalence may have changed over 2 time points. Next slide. Okay, so to talk about the objectives of the VACs, we of course want to assess the burden of violence and as well the context in which it happens, which may be unique in particular countries or even regions within countries. We want to understand the health consequences and other negative consequences of violence. It's really important to inform intervention science to understand the risk and protective factors that might put somebody at greater risk for violence experiences or in fact protect them. We want to understand for those children and young adults who do experience violence, have they ever told anyone? Have they tried to seek professional services, and were they successful in seeking those professional services when they did try? And then finally, as you saw from the map, the VACs have been implemented in a number of countries with a generalized HIV epidemic, and we know that there's a real intersection between violence and HIV. So the VACs also helps to inform violence prevention and HIV programming in these countries. Next slide. So now a bit about the methodology. We're not going to go in depth here, but there's a lot of resources that we can point you to find out additional information if you're interested. The VACs are national household surveys, and we survey 13 to 24-year-old males and females. We've determined at the very beginning of VACs that 13 was the youngest we should interview with our approach, because that's the youngest age at which they would comprehend the questions. And then in turn, we didn't want to survey beyond 24 years old to reduce the possibility of recall bias. But we do ask participants to recall violence across their lifespan. So we're collecting violence that occurred really anytime between the ages of 0 and the age that they currently are. VACs is a 3-stage cluster sample survey design, meaning we randomly select clusters from a country's frame. Within each cluster, we randomly select a set number of households. And then within each household, we only select 1 participant per household. So we randomly select a participant from amongst eligible participants in each household. The VACs are carried out by in-country institutions, and this has varied from country to country. Sometimes it's a government agency, sometimes it is an academic institution, sometimes it's an NGO, but these are people who understand the context of the country and are best placed to carry out the research. There's extensive training for field staff, particularly around the protection protocols in place for child respondents. And then finally, in a number of countries that do have generalized HIV epidemics, we have offered HIV testing and counseling, and then connected those people who test positive to care and treatment services. Next slide. So the VACs really are catalysts for action in countries, and that's built into these surveys from the very beginning. I think one of the most important aspects of the survey is that at the outset, a multi-sector task force is developed, and that pulls together all the stakeholders from the government, from civil society, multilaterals. They come together and they form a survey-specific task force that really provides guidance and leadership from the very beginning on the adaptation of the tools throughout field work. And then, of course, as we move into analysis, the production of reports, and the data to action phase of things, this group is very active in providing that leadership in the country. So VACs oftentimes is truly breaking the silence on an issue that is often misunderstood or taboo. And it starts this conversation, ultimately leading to action, which has been documented in a number of countries and is really impressive and leads to truly the prevention and the response for children. Next slide. So the surveys are really sort of this first step in the data to action process. The countries use the surveys to prioritize data points that they really feel like are a key priority in their context and they feel like are actionable. So in a workshop, they come together and sector by sector, they prioritize data points. And then they use the Inspire technical package to map those prioritized data points onto evidence-based program and policy that they can adapt for the context of that specific country, often resulting in a national action plan. Next slide. And so now I'm going to turn it over to my colleague, Stephanie.
Thanks, Laura. Good morning. Good afternoon, everyone. My name is Stephanie Miedema, and I work with Laura and Francis at the CDC on the VACs. I'm going to speak to you all today about the actual indicators, so the measures that are included in the VACs, should you be interested in pursuing data analysis opportunities with this amazing data source. So the VACs is, as Laura highlighted, a comprehensive data source on violence against children and youth. It includes data on physical, sexual, and emotional violence, risk factors and demographics, health outcomes, risk-taking behaviors, HIV/AIDS testing behaviors, gender attitudes, history of migration, and more. Today, I'll focus mostly on the measures of violence, risk factors, and some of the health outcomes that we measure, and focus on those for purpose of today. But just to let you know that there are a number of other very interesting and relevant measures that are included in the VACs, and we encourage you to explore those questionnaires, which are available on the Together for Girls website. So there are a few ways that the VACs are, that violence is measured in the VACs. The first is childhood violence, and this is defined as the first experience of violence occurring prior to age 18. And these measures are captured among youth aged 18 to 24. The VACs also collects data on lifetime exposure to violence. And so that's defined as any experience of violence from 0 to 25 among all the youth that are included in the VACs. So youth aged 13 to 24, any violence up to the age at which the participant is engaged in the VACs survey. And then finally, the VACs includes past 12-month measures of violence. And I'll get into some of the details of this measurement in a moment, but this is defined as any incident of violence that occurred within the past year. So looking first at physical violence is measured in the VACs by perpetrator type. So participants are asked whether they experienced any of these 4 indicators of physical violence by any of these 4 perpetrator types. And that's intimate partner, peer, parent, caregiver, adult relative, or community member. And in the actual sequencing of the survey items, for each of those 4 perpetrator types, participants, if they report that they have experienced any one of those 4 experiences of physical violence, for each perpetrator type, they're also asked about the frequency at which they experienced the violence, whether it occurred in the past 12 months. And then for those who experienced violence more than once, they are asked about the most recent time and the first time. And the VACs asks about number of characteristics related to those experiences of violence. For those who've experienced physical violence by that particular perpetrator just once, they're asked details regarding that one time. And then all participants are asked about injuries resulting from physical violence, as well as service utilization. The VACs also asks about emotional violence. And you can see here on this slide that emotional violence is asked with respect to 3 different perpetrator types: intimate partners, peers, or parent, caregivers, or adult relatives. And you can also see that the items specific to emotional violence are specific for each perpetrator type. I won't go into these, I won't read through them today, but know that these slides are available on SVRI's website after the webinar, so you can use those as a reference tool as well to know the specific indicators that are used for each perpetrator type for all forms of violence. So emotional violence, like physical violence, for each of the perpetrator types, participants are asked about the frequency with which they experienced the emotional violence, whether it occurred in the past 12 months, and then again, the characteristics of the most recent time and the first time for those who experience more than one instance of violence, and the characteristics of just that single time if participants experience only one experience of violence. And finally, the VACS asks about sexual violence. Sexual violence questions are slightly different insofar as the survey is structured around the types of violence rather than the perpetrator type for sexual violence. And the VACS asks about 4 specific types of sexual violence: unwanted sexual touching, attempted forced sex, physically forced sex, and pressured sex. For the last 3, the VACS asks separately whether that was by a current or ex-partner or someone else. And then here again, you can see that we capture frequency data for each of the forms of sexual violence, as well as characteristics of the most recent time and the first time for those who experience more than one instance of sexual violence of that particular sexual violence type, or the single time if they only experience it once. And I will note that for sexual violence, we do also capture relationship to perpetrator, so there is more nuance and detail with respect to the perpetrator type that are asked in the sequential questions that come after, after the frequency questions. And then for sexual violence, all participants who experience any form of sexual violence are asked about their patterns of disclosure, as well as their utilization of any support services. So the VACS, so those are the victimization questions. The VACS also asks about violence perpetration. These questions are asked of both males and females of all ages. And the questions are focused on perpetration of physical violence, and then also capture past, whether that occurred in the past 12 months, and also sexual violence and whether that occurred in the past 12 months. There are a number of other violence indicators that are included in the VACS beyond sort of the major ones that I just shared. And that includes indicators such as harsh discipline, verbal and physical harsh discipline in the past 12 months by a parent or caregiver. That's among 13 to 17-year-olds. Witnessing household violence and witnessing community violence. Technology facilitated violence, which I'm sure many of us are increasingly aware that this is, becoming quite an emerging topic in our field. Forced sexual initiation or pressured or forced sexual debut, as well as reproductive indicators of reproductive coercion among female participants. So turning now to the risk factors and consequences that are measured in the VACS. There are a number of risk factors that are included in the VACS. Here's a sampling on this slide, but again, I encourage everyone to take a look through the questionnaire and become familiar with the sort of breadth of questions that are included. We have, the VACS include a number of questions related to financial insecurity. Those are asked both at the individual level as well as the household level. So both with the individual survey as well as the household survey. A number of items pertain to social isolation, particularly with respect to peer friendships, community connectedness, and participants' relationships with parents. The VACS also includes a number of attitudes questions related to gender attitudes and attitudes toward various forms of violence. And finally, HIV and sexual risk behaviors, HIV status testing and knowledge, sexual history and partnerships, and specific sexual risk behaviors like transactional sex or low or no condom use. And finally, I just wanted to touch briefly on a few of the health consequences that are measured in the VACs. We have measures of substance use, alcohol, smoking, and drug use. We have the VACs includes mental health measures, including a scale of mental distress, measures of suicidality, and measures of self-harm. And finally, the VACs includes a number of questions related to sexually transmitted infections. So I will stop here and pass it to my colleague, Dr. Frances Anor, who will give a little bit of a background about accessing and using the VACs. So Frances, over to you.
Frances, I'm sorry, I think, oh, there you are. I think you're on mute.
Yeah, Frances, we can't hear you. No.
No, we can't hear you, Frances.
No.
No.
Still can't.
Thanks, Stephanie.
Yeah, no problem. And sorry about that all. I know we're all very familiar and forgiving of technology issues since COVID, so appreciate everyone's patience. So just to go over a few slides on accessing and using the VACs. So the VACs data, most of the VACs data are publicly available. And Together for Girls has a fantastic and very streamlined and easy to use request access process. You can see the link here. If you go to the Together for Girls website under VAC surveys, analyzing public VAC survey data, that'll take you directly to the request form and filling out that form with a few details about yourself, your organization, and the type of data you would like, in what software form. You can go ahead and submit that, and that gets routed to us, and we help to facilitate access to that data. Other than just the raw data, there are a number of data analysis resources that are available on the Together for Girls website. So each country includes a country data file. This is a very valuable tool that can help analysts troubleshoot any issues, give them a good sense of what the variables are that are needed to account for complex survey design, give information on how indicator codes were developed, etc. So if you are interested in using the VACs, I strongly encourage you to explore that data file. It's very valuable. On the website, there are also country code books for respondents, household, and HIV, and also country questionnaires are available for males and females and the household. And then also on the VACs, which I think are extremely valuable as well, are the country reports themselves. And these are wonderful tools that summarize the main findings of the VACs and help to understand what the country priorities are with respect to preventing and responding to violence against children and youth. So these are a great tool to become familiar with the data in a particular country that you may be interested in. And finally, I just want to give a plug to Together for Girls. They're leading a new VACs Data to Action research course. I believe the current course is underway or will be shortly underway. And that's currently happening now. So the 2023 course is closed, but stay tuned for course offerings in the future. This is a fantastic partnership with Together for Girls and the London School of Hygiene and Tropical Medicine to support, engage, and equip early career researchers to conduct data using the VACs, and then also to help communicate those data and those findings to policymakers and key stakeholders. And you can see the list of countries that is the focus of this particular course listed here. So that's all from us. Thank you so much, everyone, for joining, and I will pass back over to Constanza.
Thank you, Stephanie, and thank you, Laura, for providing a very comprehensive overview of the VACs. Now we are going to hear from early career researchers to learn more about the VACs data in use. So we will have Manuela Valleda. She is a PhD candidate at the London School of Hygiene and Tropical Medicine in the UK. Her doctoral research explores factors related to violence against children in schools in Côte d'Ivoire using a mixed methods approach. Manuela also serves as the Regional Research and Policy Advisor for Sub-Saharan Africa at Together for Girls. Manu, the floor is yours.
Thank you so much, Constanza. I hope you can all hear me well. Yeah,
yes.
Perfect. Okay. Thank you so much for the opportunity to present my research. Today's presentation reports on a quantitative study that explored the co-occurrence of physical violence in and beyond school using evidence from the VAC Côte d'Ivoire. So during this presentation, I will briefly present the context of violence against children in Côte d'Ivoire. I will state the aim and objectives, the conceptual framework that guided our analysis, and the methods which we used for our work. I will discuss the findings and make some recommendations for the policy. So, the government of Côte d'Ivoire implemented its first VACs in 2018, and the country is about to launch its national action plan, a strategy to respond to violence against children based on the findings of the VACs. The country has taken actions before even implemented the VACs to reduce violence against children in school. This included a formal ban of corporal punishment and all humiliating behavior of any kind toward children. And teachers received a peace culture training to reduce violence towards the students. And students as well do receive training on education life skills to reduce violence from peer to peer and in a school environments. The survey findings revealed that in Côte d'Ivoire, both boys and girls experience high rates of physical, sexual, and emotional violence. You can see from the graph here that around half of girls have reported physical violence before age 18, and 60% of boys for physical violence. The rates are also high for sexual violence, with about 20% for girls and 11% for boys, and also for emotional violence, 20%, around 20% for girls and 16% for boys. And violence can actually occurs in all the environment of the child, at home, in the community, and in school, but very few studies have examined how violence against children from multiple perpetrators and from different contexts actually overlap in the context of sub-Saharan Africa. The aim of my research was to explore the co-occurrence of physical violence, so it has a specific focus on physical violence among children in school in Côte d'Ivoire in the past 12 months. And in doing so, I attempted to address two questions. One, what is the relationship between physical violence perpetrated by household members, that is parents, caregivers, adult relatives, and also PV violence perpetrated by peers, and the physical violence as well perpetrated by teachers among children who go to school. And the second research question was to establish the relationship between the experience of violence by different perpetrators and children's involvement in physical past in the past 12 months, and whether this relationship was moderated by violence prevention education. And this includes anger management, avoidance of physical fights, and bullying. We developed this conceptual framework presented here, drawing on the INSPIRE strategies, which are a set of 7 evidence-based strategies for countries and communities to eliminate violence against children. We can see this on the first column. And then secondly, we also drew on the World Health Organization's ecological model that stipulate that violence against children is caused by multi-layered effects like community level factors, school level factors, home level factors, and the individual characteristics of the child as well. And this is particularly useful because the National Action Plan of Côte d'Ivoire is developed around the INSPIRE framework. And this will help us, it will provide a framework to interpret as well and disseminate the result of these findings for future uptake as the country is about to launch its National Action Plan. We can see in this diagram that on the first dimension, we hypothesize that community level factors such as friendships, safety in the community, witnessing violence in the community could influence the experience of physical violence by children. And then risk and protective factors were actually used as variables for this level of the analysis. In the second dimension, we hypothesize that school-related factors such as level of schooling, norms around corporal punishment by teachers, and education on violence prevention will influence the experience of corporal punishment by teachers. In the third dimension, we looked at food and material security, which is a proxy for poverty, and experiencing violence at home as well would likely cause children to experience violence by teachers. And then finally, at individual level, the child's sex, age, and orphanhood could influence experience of physical violence. So I used a subsample of the VAX data set, including children under the age of 18, so from age 13 to 17, currently enrolled to school. That gave me a total sample of around 800 children, half were male, half females. I employed bivariate and logistic regression models to understand the associations. And for the logistic regression models, these were adjusted for individual, homeschool, and community level characteristics as described in the conceptual framework. So three key findings emerged from this research. One, that the prevalence of physical violence by any perpetrator among school-going children was very high. And peers were the most common perpetrators, with nearly 1 in 4 school children reporting experience of physical violence from schoolmates, siblings, friends in the past year. These were followed by household members that included parents and caregivers at around 18%, and followed by adults in the community, including teachers, around 30% for the prevalence. We also found that male teachers are the most common type of perpetrators of the first and last episode of physical violence among those children. So second set of key finding is that we observe no association with sex. And although no association was observed, here we can see that, we've included sex as a priori, given the gender dimension of violence in sub-Saharan Africa. And this was included by our knowledge of the context. And although we did not observe any association with sex, boys had higher odds of experiencing physical violence by teachers. So also we observed that school children in a younger age group, so 13 to 14, compared to those in the reference group, which were 15 to 17, these children were about 6 times more likely to experience violence with teachers in the past 12 months. The We also found that the experience of physical violence by household members in the past 12 months make children very vulnerable and exposing them to around 3 times being more likely to experience PV by other teachers versus those children who did not experience physical violence at home. And then finally, and interestingly, at school level, children who endorse corporal punishment by teachers were twice more likely to experience PV by teachers. And this could suggest that beliefs and norms around violence against children are perpetuated and may be reproduced by children and later on in adulthood. The third key finding to highlight here is that we observe that, again, although we did not find any association with sex, that males were more likely to be involved in physical fights in the past 12 months. And for all the other risk factors, we observe a strong association with involvement in physical fights. So experiencing physical violence by household members make children twice more likely to be involved in physical fights at least once over the past 12 months. And witnessing violence in the community in the past 12 months as well increase the risk of children of experiencing PV and being involved in physical fights. And then finally, we had this strong association with the physical violence by peers. And this final variable could also be that the fact that involvement in physical fights might mean children can be perpetrators of violence themselves and victims. So we can see a correlation between physical violence by peers and involvement in physical fights at least once in the past 12 months. We did not observe any evidence of effect modification of violence prevention education on the involvement in physical fights. So what does it mean for policies, for the country, for the region? Through the study of subsample of children going to school, we were able to explore the co-occurrence of violence by perpetrators in and beyond school. This suggests that school is a powerful entry point to prevent violence in and beyond school. The fact that violence by multiple perpetrators overlap, co-occur, and this may happen in different contexts and may have secluded manifestations, call for a whole school integrated approach to address the overlap of violence. And thirdly, teachers' training should include the management of children exposed to violence against children at home and in the community. And then finally, there is a need to explore the content of the violence prevention education that didn't seem to have an effect modification on children involvement of physical fight or exposure to violence. And this should also include or address social norms that condone the use of corporal punishment for educational purposes. I would like to acknowledge my PhD supervisors at the London School of Hygiene and Tropical Medicine, Dr. Claire Tunton, Professor Karen De Vries, and Professor Shelley Lees, the co-authors on this paper, Franck Migonnet and Dr. Chadra Kabla, and the partners in Côte d'Ivoire, CDC PEPFAR Côte d'Ivoire, the Institut National de la Statistique, and the Ministry of Family, Women and Children, PNOEV and DPE, who supported this study, as well as UNICEF Côte d'Ivoire. And I would like to also suggest some useful links for further reading. So the Violence Against Children survey report for Côte d'Ivoire is on the Together for Girls website. We've also conducted secondary analysis of this data to understand the links between violence and educational outcome. And I also invite you to consult the page of the London School of Hygiene and Tropical Medicine Child Protection Research Group to explore, to see the work that we're conducting as well in Sub-Saharan Africa. Thank you very much.
Thank you so much, Manuela, for sharing your research with us. Now we are going to hear from Bolade, Madison, and Bothaina. I'm going to introduce them. So Bolade Hamed Bagnouming is a postdoctoral research fellow at the University of Cape Town. He's a statistical researcher with expertise in data processing, cleaning, analysis, interpretation, and dissemination for large-scale surveys. So Madison Little is a PhD candidate at the University of Oxford. His doctoral research examines the effectiveness of cash plus interventions and the combined impact of Inspire provision in reducing violence victimization among children and adolescents in Southern Africa. And last but not least, Botaina Echigani is a PhD candidate also at the University of Oxford. And her doctoral research focuses on examining the relationship between climate change and the risk of experiencing interpersonal violence among among adolescent girls in Southern Africa. So, Boladed, the floor is yours. Over to you.
Great. Well, I'll be kicking off with the first talk.
But okay, go ahead.
Yeah, glad to be talking with everyone here today about the work that we've been doing around HIV and violence prevention, particularly in 4 countries, Kenya, Lesotho, Namibia, and Zimbabwe. The first piece of research that we'll be talking about is us applying the Inspire framework in practice, seeing what the impacts are within these 4 countries. Within some of the background that we have heard in this webinar, Inspire is a set of 7 strategies to end violence against children. It was initially published by WHO about 8 years ago. And in that time, right around the same time, the Violence Against Children surveys started including these Inspire provisions as questions within it. So it gives us a really unique opportunity to be able to empirically test how these provisions are impacting on adolescents and young people in given country contexts. In most standard research, say, we would be testing these through randomized trials, which would cost millions and take years to complete. So some of the methods that we've been developing over the last 5 years has allowed us to look at observational data like the VAX data to be able to give helpful information to our partners and policymakers about what are the most effective intervention areas for adolescents. Within a lot of our research, we have been working to identify what we're calling development accelerators. The idea being that these are interventions or areas of an adolescent's life where if we can have impact, you see benefits across a range of outcomes in multiple aspects of adolescents' lives, whether that be in violence prevention and HIV risk reduction, as well as in education, mental health, and child marriage. And the idea behind this ultimately is that by being able to impact in these areas where we then see large scale impacts, we're having greater effectiveness in implementing these as packages because we're dealing with multiple pathways of vulnerability at the same time. And that with this, the idea would be that then there's higher cost effectiveness to the interventions that we would implement. The VAX data is amazing in its structure in us being able to have nationally representative data and is very useful for looking at the violence outcomes that were just covered. So looking at violence perpetrated by intimate partners, peers, caregivers, as well as the different forms of sexual violence. And within this particular set of analyses, when we look at HIV risk and sexual and reproductive health, we're able to look at the more proximal risk factors like sexual behavior, but also still capture the structural issues of child marriage, education outcomes, and mental health. If there was one slide to summarize the findings of what we've been seeing across the countries, it's that Inspire works. We're seeing very strong evidence across the countries that these Inspire provisions, the ones that we were able to test, food security, good parenting, and positive gender equitable attitudes, are associated with significant reductions in HIV risk and violence victimization among girls. And that even beyond that, we're seeing an even stronger effect of these accelerators for girls, which has significant implications to a lot of the work that many of us are doing and the work of the DREAMS program. To highlight one country as an example of our findings, we'll first look at Namibia. So consistent with the findings across the board. Food security, positive gender norms, and good parental support were associated with reductions in HIV risk and violence victimization. Looking at the chart, you'll see that the bars represent the relative percent change of receiving none of the accelerators versus receiving all three. And the numbers on the far right are the predicted probabilities from the same comparison of no accelerators versus receiving all three. So for example, for girls who experience food security, positive gender norms, and have good parental support, the predicted probability of child marriage goes down by 97%, which is really, really remarkable findings. And that even past that, we see more than 50% reductions in child abuse, sexual violence, peer violence, and early sexual debut or early pregnancy. And then we see continual impacts across other outcomes as well in intimate partner violence, mental distress, as well as in age disparate or transactional sex. A lot of this data, so we tested 12 outcomes, and with just these three provisions, positive gender norms, food security, and good parenting, 10 out of the 12 outcomes showed significant improvement. We then looked at it in boys, and we do see that positive gender norms remains an accelerator, and that it's associated with around six out of the 10 outcomes that we evaluated, and around 50% reductions for all of them. But the food security and parental support did not qualify as accelerators. They weren't associated with 2 or more outcomes in the analyses. So then we wanted to take it a step further and think about what does this mean in kind of implementation of interventions for these provisions. So we wanted to look at interactions between the different INSPIRE provisions to see if we get added benefits. And in fact, we do. When we look at the interactions between the 3 provisions for adolescent girls, 4 outcomes: sexual violence, mental distress, child abuse, and child marriage, all show that there's significant interactions between those accelerators between the accelerators in improving the outcomes. And so in programmatic terms, this means that we get even higher impact by implementing this package of interventions together. So that is, say, the brief overview of how we have looked kind of, say, just at one country, but then starting to aggregate some of our findings into across countries. We've been seeing that there are very similar findings across the board. We see the same positive impacts of food security, gender equitable attitudes, and parental support for girls in Lesotho. We see the largest reductions in intimate partner violence, child abuse, and multiple sexual partners, and the same in Zimbabwe, with the largest reductions, more than 75%, in intimate partner violence and child abuse. Kenya, we also had very similar results, but the sample size of the Kenya data set is much smaller than the other 3 countries. So because of the statistical power, we had to reduce the number of outcomes that we looked at, and we focused on Kenya's triple threat policy framework, looking at violence, HIV, and adolescent pregnancy. And in this case, both positive gender norms and parental support were significant accelerators. Food security was also associated with reductions in adolescent pregnancy. So when taken together, I think one of the really exciting aspects about this research is that we're seeing that INSPIRE works, that we're seeing these significant associations across a range of HIV risk and violence prevention outcomes, and that these findings are so consistent across the countries. We're seeing this cumulative effect in both the breadth of outcomes that we look at, the number of areas that we can have an impact in for adolescents, as well as in the depth on singular outcomes, that there are some interactions between the different INSPIRE provisions that suggest thinking about implementation intervention packages and multi-component programming. This research in kind of the data to action, we've had a wonderful set of partners who have worked with us throughout our research findings, and we've had a wonderful range of interest in applying our results into practice, and in particular, people working in social protection, those working to end child marriage, and major actors in the HIV movement as well. We're currently in the process of writing these up as publications and also creating policy briefs with our partner organizations. But just to emphasize the importance of this data is wonderful in giving the story of what situations look like for adolescents, and in applying these findings to practice, continuing to engage with these adolescents and young people is a critical component of that. We've been working with youth-led civil society organizations to discuss a lot of these findings about HIV drivers, and kind of working together to brainstorm how we can improve prevention efforts. So having the access to the Violence Against Children surveys has allowed us to really start to think new ways about examining interventions and the ways that we can impact multiple aspects for adolescents in a high impact and cost-effective way. So with that, I will now pass it off to Balade, who will talk about some of our broader multi-country studies that are going on. So Balade, over to you.
Thank you so much, Madison, for this great presentation. We started on behalf of an NIH grant, a study on, and we are trying to look at how childhood adversities are related to adolescent outcomes, health, HIV-related outcome when they become adults. Next slide, please. And we work on countries in Southern Africa, including Lesotho, Namibia, and Zimbabwe, combine the data sets, including adolescent young women aged 18 to 24 years old, and in Lesotho, 2018, Namibia 2019, and Zimbabwe 2017. And the largest sample size was in Zimbabwe and Lesotho. And can you go to the next slide, please? And here we focus on the young women aged 18 to 24 years old to account for temporality. So we look at how childhood and early pregnancy experienced by those children when they were before age 18 affect their SRH and HIV related outcome when they become adults from 18 years to 24 years. And then we did a multivariable look binary regression to look at how these early pregnancies and sexual violence in childhood are associated with SRH and HIV-related outcome in adulthood. And then we estimated relative risk from the regression and look at the potential interactive effects between the two types of adversities on HIV and sexual SRH-related outcomes. Next slide, please. In our analysis, we assessed 7 outcomes, including unprotected sex, inequitable sexual partnership defined as reporting sexual intercourse with a partner that was 5+ years older than the young women, or sex in exchange of money or any material supports, and then multiple sexual partnerships, sex with 2+ partners. And we also assess intimate partner violence revictimization in the past year, substance use and mental health using the Kessler 6 scale. The main exposure here were sexual violence before the age of 18 and early pregnancy before the age of 18. And we adjusted our analysis with the age of the young women, orphanhood, education, and being in a relationship, ever been in a relationship. Next slide, please. So this is how our sample is distributed. On average, in all 3 countries together, participants were 24 years old, and 40% of them lost a parent or both. Then most of them were already in secondary or higher education. This is understandable. We are working here on a sample of 18 to 24 years young women, and then 37% of them were already married. Regarding the childhood adversities, 12% of them reported sexual violence before the age of 18, and Zimbabwe had the lowest prevalence of childhood violence, and Namibia and Lesotho had a higher prevalence as compared to Zimbabwe, but they are quite similar. And 14% of adolescents in all 3 Southern African countries reported a pregnancy before the age of 18, and Zimbabwe had the highest proportion of young women who reported ever being pregnant before the age of 18. Namibia and Lesotho had lower prevalence, but they are quite similar. And on the next slide, we then looked at the prevalence of various violence and HIV/SRA-related outcomes in those young women aged 18 to 24. And 53 or more than half of the participants had reported having sex without the use of condom, and Zimbabwe had the highest prevalence. Lesotho and Namibia are quite similar, and 23% of them reported inequitable sexual partnerships. Zimbabwe with the highest, and 6% reported sex with 2 or more partners, and Zimbabwe having the lowest proportions, and Namibia and Lesotho being similar. And then 10% of the young women reported IPV re-victimization after the age of 18 in the past year. And Zimbabwe has the lowest proportion. Namibia and Lesotho are quite similar, and 11% of the young women reported substance use, in Namibia having the highest proportion, Zimbabwe the lowest, and Lesotho standing somewhere in between those 2 countries. And 15% of young women aged 18 to 24 reported mental distress in the past 30 days, and Zimbabwe had the highest proportion, and Namibia the lowest. And if we look at the next slide, where we reported findings from our multivariable regression, we found that childhood sexual violence in early pregnancy were systematically related with increased risk of inequitable sexual partnership, IPV re-victimization, and mental distress in young women aged 18 to 24 years old. And then there were increases of sexual, multiple sexual partnership, and when adolescent had reported sexual violence before the age of 18, and then increases of condom-less sex and substance use in the past 30 days when adolescent report when those young women reported having had a pregnancy before the age of 18. And then we look at the compound effect of both early pregnancy and childhood sexual violence, and found that there was extra risk of reporting inequitable sexual partnerships and intimate partner violence revictimization when those young women reported both sexual violence in the childhood and early pregnancy. Thank you so much. And then I will pass on to Botsaina.
Thank you so much, Bulade, and hi everyone. My name is Buthaina. Thank you so much for attending, and thank you for giving us the opportunity to present our research. I will be talking about an ongoing analysis that I'm currently conducting for my first PhD project, and in efforts to answer the following question. Madison, please, next slide. The question I'm trying to answer is that, does exposure to drought increase the risk of violence against adults and girls in Southern Africa? These are some of the variables, or all the variables, that I'm interested in and included in my analysis. If we start from the left side, you can see my exposure variable, which is the drought. And then I will be conducting analysis to analyze the risk of drought on several outcomes, which are the violence outcomes on the VAX datasets, which are sexual violence, emotional violence, and physical violence. I will not be disaggregating the physical violence, so it will encompass violence perpetrated by family members or community members and peers as well. And then in the middle, we have my demographic variables, which I classified into covariates, which will be my control variables that consist of age group, gender, education attainment, and orphanhood. And then the effect modifiers are going to be a set of vulnerability variables. So that the purpose of the effect modifiers is to see whether the risk of drought on experiencing violence differs by certain vulnerability factors, whether that be being an adolescent mother, or being an orphan, or living with HIV. As we know, violence is not experienced the same by everyone. So I think it's important for us to differentiate and also analyze how different subgroups, and especially those who have different layers of vulnerability, experience violence differently from their counterparts. Next slide, please. So the methodological approach that I'm planning to adopt here is in 3 stages. So the first stage will be analyzing the VAX datasets. As I said, this will be the VAX datasets. We all know it's nationally representative datasets. I will be focusing on Southern African countries. That includes Botswana, Lesotho, Namibia, Mozambique, and Zimbabwe. So first of all, it's very important to understand each country, the prevalence of violence in each of these 5 countries, and also understand the demographic composition of the country. So how many people that are orphans and how many people are living with HIV, and also all the demographic background like age, education attainment, and socioeconomic status. After that, I will cross-tabulate violence variables with demographic variables just to observe for any patterns across the data sets. And this will help me to understand how each country has, whether there are any like distinct patterns, like for example, if people living with HIV are experiencing a certain type of violence. I think this is important to capture before conducting the main the main analysis of and trying to answer the research question. And then after that, I will merge the VAX data sets and then go to create my drought variable. Thank you, Madison. Yeah, so we'll be creating my drought variable, which will be created by using data from the CHIRPS, which is climate hazards with infrared and precipitation with station. Precipitation is missing here, so excuse me. We'll be conducting analysis on the annual cumulative precipitation over the preceding 12 months for each survey date, and the district area which will be calculated. So unfortunately, this method needs geocodes, but with the VAX data sets do not provide geocodes with the main data, and this is because of privacy reasons and security reasons, and also the decision goes back to the country. Whether they want to share the geocodes or not. So because I don't have that data, I will be doing it on conducting the analysis on the level of the district area. And the ward district will differ obviously from country to another. Some countries call it a region, some other countries will call it a district. So, and I will talk later about how can this be harmonized across data sets. After that, the precipitation amount will be ranked in millimeters and then converted to a percentile. Converting the drought variable into a percentile will generate an ordinal categorical variable of drought, which encompasses severe, mild, and no drought. And according to that, I will be analyzing to see the effect of each level of drought on experiencing the violence types. Next slide, please. The third stage will be the geospatial analysis. The drought variable will be merged with the VAX survey data set using ArcGIS. I have still not reached this level yet, so I can use ArcGIS or use R, the R program itself. So this can be done using either programs. And also the merged data sets then will be analyzed and visualized. Visualization is important at this stage to understand, because it will give us an idea about not the impact, but the association between drought and the intensity of drought on the risk of experiencing violence. So, and where is that concentrated, in which areas in the country maps. So seeing these maps will also make the process easier, and the researcher will be able to understand the data better. After that, and finally, the multivariate logistic regression models will be conducted to provide a nuanced understanding of the association between drought and violence exposure. Next slide, please. So for the long term, it's important to address or think about what would be the policy implications of the research one is trying to conduct. So as you can see, this is an integrated interdisciplinary approach. And in my opinion, I believe that the findings may inform policy makers to invest in climate mitigation strategies, especially in drought-prone regions, to tackle its indirect risk on violence exposure. I also believe that these findings may also promote an interdisciplinary approach in addressing these social risks of climate change. It will also highlight the importance of enhancing and developing early warning systems that are sometimes existent in some of the countries I will be analyzing, but other countries may want to invest in these systems more because they anticipate the risk and hence can be prevented before happening from the first place. And the last policy implication would be to generally encourage policymakers to foster a sense of collaboration between sectors and relevant ministries and departments to work together and to mitigate the impacts of drought on violence exposure. Next slide, please. And finally, the Accelerate Hub, where Madison, Bulade, and I work at, has been successful in policy engagement with several global initiatives, which are included in this slide, and whose grants enabled the hub to influence policy and bring about change that affect positive impact on the lives of adolescents and children. Next slide, please. On this slide, you can find the resources on our Accelerate Hub website, and I'm happy to provide the links then in the chat or the Q&A if anyone is interested to search more about the work that the Hub has been doing and the different policy engagement activities that we've been doing. Next slide. And last but not least, thank you so much to Together for Girls, CDC, and PEPFAR for their inputs and your engagement and giving us this great opportunity to share our research. Thank you so much.
Thank you, Wataina, Bulade, and Madison for sharing with us your research. I'd like now to ask some questions to you to learn a little bit more about your experience using the VACS data. I will start with Manuela, if that's okay. Could you please state the main challenges that you have experienced with your VACS research, and if there is any advice that you would like to give to new researchers working with the VACS data?
Thank you so much. Thank you, and thanks to all the co-presenters. What great presentation. First, before talking about the challenges, I wanted to say how much I enjoyed my research. It felt really wonderful to engage with local researchers in Côte d'Ivoire, stakeholders. VACS was groundbreaking in Côte d'Ivoire, and I was able to engage with the government stakeholders from the Ministry of Education, Ministry of Women, Family and Children to discuss my work from the beginning and throughout. So this is very exciting, and I've also been invited to discuss my findings and the research implication with the country stakeholders as we're about to launch the National Action Plan. So these are great prospects. In terms of hurdle, I would say the biggest challenge for this VACS research in my case was that of funding. Funding was a very important point, and I believe many researchers in the region will also identify to this point, and especially in the West and Central African region where I work. This region has around 25 countries. Children in this region represent 12% of the world population, and researchers have a very limited outreach, and this limits the huge potential that they have, and the region as well, to prevent violence against children. We can see this in the first authors publication that we have, access to platforms. It's true that my university is based in the global north, but most of my research collaborators are based in the global south, and I can really see that the challenges that we have that they have, so we all have as a community, to access platforms, online libraries, journals, software for data analysis, constitute barriers. The fact as well that Côte d'Ivoire is one of the 2 countries non-English speaking in sub-Saharan Africa which have conducted the VACS beside Mozambique, and this has limited access of researchers to international conferences and platforms to showcase the amazing work that they do. And Côte d'Ivoire really presents a unique opportunity to reach out to other regions. Benin, Mali, Burkina Faso, all the surrounding countries, they have platforms to collaborate on child protection. And it would be really important to think as a global community how we can ensure that researchers who are skilled and talented and the momentum is there, have the skills, the fund and the resources to move forward the agenda. My advice to early career researcher, my first one is to keep dreaming big. We can eradicate violence, and we cannot stop the research because we do not have the resources. We can do research with the limited means that we have, and this we can see they've done fantastically. So keep dreaming big. The second thing is to really create collaboration platforms with local and regional researchers. I was really lucky being in the UK to create this bridge as well between Côte d'Ivoire and the region in terms of local researchers. And then, third, visibility. We want to ensure that, we provide platform for these researchers to, present their work through webinars and conferences, and together we will eradicate violence. Thank you.
Thank you, Manu. I really like that. I'm turn over to Madison. Could you please comment on preparing data sets for analyzing for multiple data countries?
Yeah, that sounds great, and that definitely goes into at least one of the questions we saw in the chat. Kind of this question of standardization. When we started doing the VACs analyses, we started analyzing each country separately so that we could really get into the data, understand the context, and figure out how best to apply our method approach. And as we kind of came to the end of the major exploratory period, we started trying to make sure that our analyses were harmonized across the country data sets that were going on. And largely the questions do overlap. There will be groups of modules that I'm sure that other CDC people can cover in greater detail, but all in all, there's very consistent research questions and wording between the different data sets. But what we found is that in preparing for multi-country analyses, we found that it's been best to analyze or prepare the data sets for the individual countries first prior to merging. Just as one example, one of the variables we had been looking at, the questions are worded the same, but in two countries, the question was only asked if the child was not orphaned prior to age 13, and that wasn't necessarily a clause in the other two countries as to how the question and questionnaire was worded. So there is a large amount of overlap and consistency between the countries that enable for multi-country analyses, and is certainly a feasible task, but we just found that it was the safest option was for us to analyze each country separately so that we could make sure we really understood the nuances in the data.
Thank you so much, Madison. That is so clear. I'd like to move to Bolade. So could you please discuss the application of survey weights when analyzing a single country and also multiple countries?
Yeah, thank you so much, Constanza, for your question. Yeah, the first, okay, when you have access to the VAC data set, you are provided with that summary document that say how to set the survey parameters, the stratum, the pH, primary sampling unit, and then the survey weight. And then what we noticed with a country like Kenya is that we found that there were strata where we have only one cluster, like primary sampling, like a single unit, and then we try to solve that situation, affecting to those specific strata the ground mean average value instead of using the stratum mean. And then, yeah, and I know for people using other software like SAS, this is taken into account systematically. And yeah, and I have the opportunity to ask Francis that question, and yeah, and he confirmed, he might say it again here. And then in the multi-country analysis, based on the fact that the sample size from Namibia, Lesotho, and Zimbabwe were quite different, we we try to find a way to make the estimate more reliable because they are not accounting for the same proportion in the whole data set. So we kind of created the final weight variable that kind of equalize the effective weight across countries to make countries a sample size account kind of equalize them. Yeah. So this were the challenge we faced during our analysis regarding weighting the estimate. I don't know if that answers your question. Thank you.
Yes, yes, you did. Thank you so much. We are running a bit late, so I will ask Botaina one more question. And then if you have more questions, please just raise them in the Q&A box. I saw that most of them are already answered, but if you have more questions, just feel free to write it there. And my question for Botaina is, could you please give us a brief overview about your experience in merging the VAC's datasets?
Thank you, Constanza. And for the interest of time, I will be very brief. So I'm currently merging the VAC's datasets. I still haven't done yet, but I can share some of my experience. I think as a first step, researcher must familiarize themselves with the structure of the data set and the variables included, as well as the unique identifiers that they will use to streamline or merge the data sets together. After the data is prepared and the researcher ensured that the data is compatible and consistent, they will need to standardize the variables names across data sets. So you will choose a name that will be the same thing across data sets, and then ensure that the variable is recoded the same way across all the data sets. And for you to do that properly, a great tip is to create an Excel spreadsheet with the variables of interests in all surveys classified by the country. And then this will help to observe for differences between how each variable is named in the data sets, and then will help the researcher also to rename the variables without missing an important one. So this will ensure to capture all the variables included in your study. And after that, merging the data set, you can check for data integrity by removing duplicates if there are any, and check for inconsistencies or unexpected patterns by comparing the merged data set with the original individual country data sets that you have to verify that they were merged correctly. And then obviously conduct your main analysis on the merged data set at the as a last step. Hope that was clear. Thank you.
It was, Botaina. Thank you so much, and thank you to all the speakers and participants for joining us. I will now turn over to Liz Darnell. She's the Executive Director of SBRI. Liz, over to you.
Thank you so much, Constanza. I just wanted a few words. I was so happy when Laura, Stephanie, and Francis reached out to the SBRI with the idea of this webinar. And that's really especially because we really greatly value research done using secondary data. And why do we value it so much? It's because it's ethical. So by using secondary data for improving policy and practice, what we're doing is deeply valuing and respecting the time, the ideas, the many challenges participants often face to share with us their work, their experiences, their lives, and their stories. And I really want to emphasize this next point before we close this webinar. Rather than going out and bothering people for more information, as a field, we really need to ask ourselves, is primary data collection necessary to answer your research question? Is there secondary data out there that we can use? And in the VAX field, I think these answers to these questions might sometimes be no, it isn't necessary, particularly because we have the VAX data sets. The VAX data provides researchers with an accessible, a convenient, and a cost-effective tool, because you don't actually have to go and collect the data yourself. It's there. And it provides an opportunity to use existing data to answer those really important questions to inform policy and practice at country, regional, and global levels. And of course, if you don't have to collect the data yourself, it leaves you as a researcher, a practitioner, with much more time to do that really fun stuff of theorizing around your data, for analyzing your data, for writing it up and using and sharing those findings with those people that can use it to improve the lives of women and girls and children. Also important is that the VAX data has been cleaned, so you don't have to do that either, and has been created for reuse. So when you go to get ethical approval and your colleagues say, is it ethical to use this data? You can say, sure, of course, because it has been, so during the informed consent process, consent was gained for the research of this data. So it is a very ethical data set and an ethical process. So this powerful data set must be used in the service of children and families. So please share the availability of this data set far and wide. And finally, I'd like to thank all the CDC colleagues for this idea, for this important panel, for Together for Girls, for your partnership, and for the excellent moderation of this webinar. Thank you. I want to also thank the excellent panelists on your presentations by Manuela, Madison, Boladia, Bathana, for sharing how you are using the data in such creative and very important ways. Thank you to the interpreters for volunteering your time, and for everybody else like Liesl, who's worked hard to make sure this panel happens. And I want to thank all of the participants for joining us. Thank you.
Thank you all.